Hello and welcome to Cognitive Enhancers, when to start, what to expect, when to stop. This is part of a talk that I did for Freeport Physicians Day in Kitchener on May 1st, 2019. No conflicts of interest. These medications have been out on patent for a long time and I do not get any benefit from using them or not using them. I may give some off-label recommendations during this talk. And this is what we're going to talk about. So we'll start with a bit of an overview of cognitive enhancers. We'll talk about when to start, how to start, when not to start, what to add, when to stop, and when not to stop. Have I said start and stop enough times during this intro? So let's get into it. And let's start with a case. So consider this is a typical type of patient that we might see in a memory clinic or in a geriatric medicine office. 78-year-old lady who happens to be a retired head nurse of the local hospital. She is very well put together. She's very vivacious, but it's clear that she has some difficulties with memory. And the family does report that this has been happening in a slow and gradual way over the last couple of years. But in the last 1 year, definitely husband has had to take over some of what we would call the instrumental activities of daily living. She does have a past medical history of type 2 diabetes, hypertension, and some anxiety. And the medication list is there. So it includes treatment for diabetes, sertraline, which is an SSRI for depression and anxiety, and ramipril for blood pressure control. We do cognitive screening with the Montreal Cognitive Assessment, or MoCA, and score is below what would be normal. Normal is 26 or higher, and this lady scored 20 out of 30, with 0 out of 5 on a short-term recall list of words. Physical exam unremarkable, and labs, including imaging, was unremarkable. So what's the diagnosis? Well, as best as we can tell from clinical exam, would you say that this is Alzheimer's, vascular, mixed dementia, or is it not dementia? Is it mild cognitive impairment? So it's a little hard to tell just from that brief scenario. However, it could certainly have a component of vascular dementia, but the story and the course and progression and presentation is highly suggestive of dementia of Alzheimer's type. And because there's functional impairment, it's not mild cognitive impairment. What is the treatment? So would you go ahead with DONEPEZIL? Would you give ginkgo biloba? How about stopping the sertraline? Maybe that is interfering with cognitive performance. What about memantine? Maybe none of these or all of the above. Well, this is the type of patient that I would probably offer a trial of cholinesterase inhibitor, and we'll get into talking about why. On average, how many points on the MMSE do patients improve with DONEPEZIL? So our patient was screened with the MoCA. When many of these medications were initially being studied and approved, the patients were being screened with the mini mental status exam. So that's another test that's scored out of 30. But how many points would you expect to see improvement? So 0 to 1, 1 to 2, 2 to 3, or more than 3? So on average, it's 1 to 2 points on an MMSE. Fairly modest. Of those who are prescribed a cholinesterase inhibitor, what percentage would you say have an adverse event? So it's probably around 25% based on both industry and post-hoc, post-marketing rather studies. So not an insignificant number. And of those prescribed, how many will discontinue within a year? So it kind of depends on who you ask, but is it in industry-sponsored studies, it's 5 to 10%, but in post-marketing studies, it can be as high as 50%. And that seems a little bit high to me. In my practice, I would say it's probably about 30%. So what are the cognitive enhancers? So there are 3 that act on acetylcholine. That's DONEPEZIL, galantamine, and rivastigmine. And then there is memantine, which is the NMDA antagonist. I'm mostly going to talk about cholinesterase inhibitors today. And what should you consider before starting a cognitive enhancer? Well, the diagnosis, because it's not, cognitive enhancers are not for normal age-related memory change. They're not for MCI. They're actually indicated for dementia and only certain types of dementia at certain stages. As well, I think it's important to consider whether there are any relative contraindications to starting a cognitive enhancer. So before starting, consider the diagnosis. Is it dementia or major neurocognitive disorder? Is it Alzheimer's or mixed dementia with Alzheimer's? Is it mild, moderate, severe, or end stage? And are there any contraindications, which we'll talk about briefly? But it's also important to consider whether it's likely that there will just simply be an intolerance, or whether there will be some cost associated with it that'll make it harder for the person to adhere to that regimen. Let's just review briefly the definition of dementia or major neurocognitive disorder. So there has to be a decline from previous, and it has to be in one or more domains, including things like memory, language, complex attention, perceptual motor or visuospatial, executive function, and social cognition. So those changes can be ascertained from taking history from family and doing screening tests in the office. And we do have to see that these changes are interfering with function to a significant extent. And it can't be solely due to a delirium or some other medical condition like depression or something else. This slide has changed numerous times over the almost 20 years that I've been in practice, but dementia of Alzheimer's type is probably still the most common type of dementia, followed by vascular, and probably there are definitely some people with a mixed picture in between those two pots. Probably about 15% is dementia with Lewy body, and then 5% is frontotemporal dementia or other types. Remember that Alzheimer's has an insidious onset and a progressive course. And it is marked by difficulties with memory, with often preserved social graces, but definitely memory would be typical of Alzheimer's, although there can be atypical presentations for sure. To sort of feel that it's Alzheimer's, we would prefer to not see substantial cerebrovascular disease or other features that suggest other types of dementia. So when we make a good clinical diagnosis, it's probably 70 to 87% sensitivity. So it would be great if we had a good blood test or very typical features on a scan, but that's not the case. We do often use CT scanning or other types of imaging, but that's usually to exclude other pathologies. On Alzheimer's, we may see medial temporal atrophy on an MRI or CT, but often the scan is normal. We can use tests such as FDG PET or SPECT scanning to distinguish Alzheimer's from dementia with Lewy body, and such things as amyloid PET scanning and CSF markers of tau and amyloid can be used, but are mostly used in research at this stage, so not really used for diagnostic or clinical purposes in Canada. Now, the severity is also important. So we want to look at where people are in the severity scale, and we could use a mild, moderate, severe scale, or we could look at the 7-stage Riesberg global deterioration scale. So looking at this, you can see that 1 and 2 are basically cognitive performance is normal on screening. There may be some subjective change in memory, but once we're getting into abnormal screening, that's at least mild cognitive impairment. And once there's functional impairment, then that is basically meets criteria for major neurocognitive disorder or dementia. And as we progress through the stages, the changes are marked by more change in function, more difficulty in functional tasks. Cholinesterase inhibitors came along during my medical school days. So prior to cholinesterase inhibitors, there really was no treatment that was directed at the Alzheimer's disease itself. So there was definitely treatments for some of the symptoms of Alzheimer's, like the responsive behaviors and so on, and depression. but there wasn't really anything that was aimed at treating the dementia itself. So cholinesterase inhibitors came along. Now, some people probably remember Tacrin, which had major challenges with tolerance and side effects, and so was not used, but Aricept or donepezil was the first one to be approved. Galantamine was second, and then rivastigmine, and those last two were initially twice a day. Galantamine then came out with an extended release formula, and rivastigmine actually comes in a patch form. So in Ontario, all of these medications are covered on the Ontario Drug Benefit Formulary, but the rivastigmine patch is not. That's not covered. Normally we start at a low dose, so half a dose, so donepezil 5, galantamine 8, rivastigmine 1.5 twice a day. And we would advise that the medication be taken with food because the most common side effects are nausea, diarrhea, anorexia. I've had patients also report that things just get a bit more leaky and runny, like a runny nose. Some people complain of bladder, more difficulties with bladder. So that could be something that's important as well. And this diagram just kind of shows the mechanism of what the acetylcholinesterases do, or, blocking the acetylcholinesterase would prevent the breakdown of acetylcholine. And then rivastigmine also acts on butyryl cholinesterase. So it's actually interesting to look at some of these studies that have been done about 20 years ago when these medications were first coming out. Because as they were coming out and as guidelines were being developed, we just sort of, it became sort of, a practice pattern to offer cholinesterase inhibitors and not really go back to the primary studies that often. So I thought it would be interesting to pick one and look at it in a bit more detail. So here's one from 2001. There were some Canadian participants in this study. You can see Serge Gauthier and Howard Feldman. But basically this was a 24-week study, randomized double-blind of donepezil in moderate to severe Alzheimer's. And the primary outcome was the clinician's impression of change, interview-based impression of change with caregiver input, which is kind of a Likert scale. Are they better? Are they worse? Are they the same? That was the primary outcome, and then looking at other features of outcomes like MMSE, the DAD, which was sort of a functional scale, NPI or neuropsychiatric inventory, which looked at function and behavior, mostly behavior. So the average MMSE was around 12, and as mentioned, their primary outcome was the civic, but they looked at other markers as well. So this is one of the graphs from that study. And you can see this is the primary outcome, right? So this is the civic. And the mean difference is fairly modest, so 0.54 on the 7-point scale. And 63% of the treatment arm were the same or better. But 42% of the placebo arm were similarly the same or better. So really the actual difference between those two groups is not that great. Looking at the MMSE or the standardized MMSE, which was used, the mean difference was about 1.79 points on a 30-point scale. So really not a huge difference, but a real difference. But there was some significant difference. I'm not going to say there wasn't, but it was modest. And then looking at the disability scale, there was some difference there. However, it's important to consider that, despite these changes on these secondary outcomes, the primary outcome was the global impression of change, which didn't change that much. And finally, looking at the neuropsychiatric inventory, there was, again, some mean treatment difference of 5.64 on that neuropsychiatric inventory scale, which looks at responsive behaviors in dementia as measured by the NPI. So I would say that it pretty much has been the standard of practice to offer cholinesterase inhibitor therapy for people with Alzheimer's, and that's reflected in the different guidelines that are out. There's even been a Cochrane analysis. So Cochrane is the database of systematic reviews, as it says there. But when there have been numerous papers published on the same topic, it's possible to do a synopsis of all of these analyses in some cases. So this was done within the last year, 28 studies, over 8,000 participants. And this study shows that there was some change on cognition. So if we're looking at MMSE, and this is the 10 milligram dose of DONEPEZIL, which is the dose that we usually try to get up to. So there was a mean difference of 1.05 points on the MMSE. So modest, but significant. This is again this CIBIC, so like this global scale, so almost 2 points difference there overall. And again, looking at NPI, there was some small change. Touches 0 there, so not really statistically significant. So overall, mild improvement in cognitive and functional scores, but no behavior change. Looking at the data from the meta-analysis, the discontinuation rate was about 5 to 10%. So most of these studies were industry sponsored, and about 27% had an adverse event. There was no benefit over 10 milligrams a day. So there have been some preparations with higher doses of DONEPEZIL. Some of the studies indicated higher scores on cognitive screening tools, but no real improvement in function and higher risk of adverse events. Below 5 milligrams, not much benefit, and really not that much difference between the 5 and 10 milligram doses. This was something I thought was interesting, was more recently published pragmatic trial looking at participants in a memory clinic and being followed for about 18 weeks. And this test found that 58% of people actually discontinued therapy, which seems a bit high, but in my practice, I would say it's at least a third. And it is for various reasons. So most of the time for some adverse event. Sometimes it's related to cost, although the cholinesterase inhibitors are generally covered in Canada for most, other than the patch, which is not covered. But people forgetting, losing prescriptions, just prioritizing other aspects of the person's care rather than making an effort to get this medication in every day. Cognitive enhancers have been studied in many types of dementia, including frontotemporal dementia, which includes Pick's disease and ALS-associated dementia, or dementia with motor neuron disease, and not found to be of benefit. Same with alcohol-related dementia. Lots of studies in vascular dementia. There have been some improvements in testing, although a higher rate of side effects. There's mild cognitive impairment, no benefit, nor is there in delirium, although there have been some positive studies, but many negative ones as well, and it's not considered the standard of care to use cognitive enhancers in delirium. I should mention that, just going back to the previous slide, if somebody has a I can't go back to the previous slide on this, sorry, but if somebody has a discontinuation of cholinesterase inhibitor due to an adverse event, I will usually stop it and then offer a different one in the same class. So if there was an adverse event with Aricept or DONEPEZIL, then offer galantamine or re-challenge with the same compound later, just to make sure that it wasn't due to some other confounding factor. Sometimes and then on this slide here, sometimes if somebody has one of these other syndromes, what I think is one of these other syndromes or disorders, it may also be an atypical presentation of Alzheimer's. So sometimes I will try a cognitive enhancer if usually that's a negotiation with family if they are very hopeful or really wanting to try a medication. But it may not be the type of dementia that it will help. We will sometimes try to see, but then it's usually done on a time-limited basis. The only absolute contraindication to a cholinesterase inhibitor is the like an allergy to it, but we do use it in caution with those with bradycardia related to a heart block or a high first-degree block. If there's bronchospasm, such as in untreated or not well-controlled asthma, an actively bleeding ulcer, a prolonged QT interval, if there are seizures, if there is pre-existing GI difficulties or anorexia or low body weight. Sometimes in advanced age, there's sort of a cost-benefit analysis. Or if there is an unreliable delivery system, which is basically if I really feel that there's going to be a challenge with adherence, then it's not something we would probably move forward with. In Alzheimer's, there is a benefit for rivastigmine and galantamine, so it seems to be sort of a class effect for the cholinesterase inhibitors. Galantamine has been well studied, or has been studied in MCI, which did show some improvements in cognitive outcomes, but for some reason there was an excess death rate that isn't really well explained, and we don't use that. Let's just look at memantine, partial antagonist rather of the NMDA receptor. Excess levels of glutamate are thought to be neurotoxic as glutamate is excitatory. So memantine in antagonizing that receptor may be neuroprotective. It can be used on its own, so for those who have a contraindication to a cholinesterase inhibitor, or it can be added on to a cholinesterase inhibitor. Cochrane database review has been done of memantine as well. It did show some mild effect, about 0.21 on a CIBIC scale in moderate to severe Alzheimer's. And again, similar lack of efficacy in the other disorders that we don't use cholinesterase. An interesting study was the DOMINO-AD study, which looked at people who were on donepezil already, so had a diagnosis of moderate to severe Alzheimer's and were already on donepezil. And then there were 4 arms. So either the donepezil was stopped and placebo memantine was given. Donepezil was stopped and actual memantine was given. Donepezil was continued and placebo memantine was given, or donepezil was continued and actual memantine was given. So then there was a comparison to see what happened. So there would be one arm with the donepezil being stopped and nothing being added, donepezil being stopped and memantine being added, and then donepezil being continued with nothing added or with memantine being added on. It was almost 300 patients, and the patients were randomized to these different arms. And this is a bit of a busy slide, but basically looking at function and cognition, there was worsening in cognitive performance on MMSE with the donepezil being stopped. Similarly, looking at function, so the direction of change is opposite there, so improvement is a lower score. And again, when the donepezil was stopped, the change in function was more marked. So my takeaway from that is don't necessarily stop the donepezil. A few years later, again, from this group, they looked at They did some post hoc analyses and looking at secondary outcomes, mind you, but they did find that for the first 12 weeks of the study, there was a reduced rate of nursing home placement if the donepezil was continued. There have been other studies looking at cholinesterase inhibitor discontinuation, and this seemed to find that when the cholinesterase inhibitors were stopped, there was overall a worsening of cognition and behavior. This is pulled out from that study there, and this was a meta-analysis of 5 trials. So this would seem to show that the overall, the behaviors, so as measured by the neuropsychiatric inventory, got worse when the cholinesterase inhibitor was discontinued. Similarly, on cognitive performance, there seemed to be worsening with cholinesterase inhibitor discontinuation. And these are from the British guidelines, but basically this indicates that it's maybe, this is grade 2B evidence, but may be reasonable to continue with cholinesterase inhibitors even in moderate to severe Alzheimer's. Now, those other trials that I mentioned excluded very severe or advanced or end-stage dementia, at which point it might be obviously be reasonable to discontinue. So, you know, I think it used to be practice to discontinue when someone was going into a long-term care home or moving into a more severe stage, but I would say that my practice now is to continue with the cholinesterase inhibitor, but that's a decision that we would make on an individualized basis with the patient and the care partners and the families. So overall, when to start? Started in Alzheimer's, mild to moderate stages, or even beyond, and continue with it into the more severe stages. Is there a role in vascular? Probably not. There is a role in dementia with Lewy body and Parkinson's related, so I didn't touch on this in too much detail, but there definitely is evidence in dementia with Lewy body. Memantine can be used in any of those conditions as well, and even in the more severe Alzheimer's. Do not use cognitive enhancers in mild cognitive impairment. And this is just, again, looking at the severity scale. So throughout mild, early, moderate, and moderately severe, perhaps even severe, we would continue the cholinesterase inhibitors. We might not start a cholinesterase inhibitor in severe dementia, but maybe we would be a little bit cautious in stopping it. These are just some of the guidelines that have been published in Canada and in the UK, if you're interested. So going back to our case, this is the type of lady that we would offer a cholinesterase inhibitor. We would start at the half dose, so perhaps Aricept 5 milligrams a day. We may not increase it past that 5 milligrams a day if it's well tolerated and if there is some response, or if the preference is to stay at that dose. Otherwise, we would increase it up to 10 milligrams a day and see them again in 3 months to see what happens. So remember that the medication is just one small piece of the management of dementia. There are things that patients and families can do to manage dementia, which includes things like living a healthy lifestyle that includes exercise and socialization, paying attention to vascular risk factors, identifying and managing as necessary, and referral to Alzheimer's Society for education and support. So valuable and so important. But medication is a part of the puzzle. So I hope that this has been helpful in giving a bit of an overview about why we use cholinesterase inhibitors and what to expect from them. You've probably gathered that my expectations are fairly modest. And I think when framed as such, when offering a trial of a cognitive enhancer, it can be much more satisfying when the expectations are kind of framed as being somewhat modest. So thanks very much for your attention, and I'm happy to discuss anything that's in the presentation. Thanks a lot for listening. Bye.